Hi, my name is Dr. Wes, and today we're going to discuss adrenal adenoma, the neuronal linkage. Adrenal adenoma is a benign tumor of adrenal cortex, uh, the outer part of adrenal gland located above the kidney. The neuronal linkage, brain pituitary adrenal axis and sympathetic nerves relate to benign adrenal cortical mass that does not secrete excess hormone. The HP axis is very important. Hypothalamus pituitary adrenal axis plus sympathetic link, uh, and especially the region of medulla. These are the regions that play a key role in non-functional adenomas as well as in functional adenoma of the adrenal gland. Core message: adrenal gland communicates with the brain through neuroendocrine and autonomic pathways. Adrenal cortex releases cortisol, aldosterone, and adrenal androgens. Adenoma, benign growth in cortical tissue. No access, no clinical significant hormone secretion is there. Therefore, no classical Cushing, Cones, androgens access or catecholamine type syndrome is expected. Normal brain adrenal neuronal linkage. The HP axis is very important. Uh, Hypothalamus, pituitary. These are the regions, hypothalamus, uh, through which CRH release, pituitary, ACTH, and adrenal cortex, the cortisol and aldosterone. Sympathetic and adrenal system, brainstem, spinal cord, and adrenal medulla. These are the regions through which the sympathetic adrenal system correlate with each other. Non-functioning adrenal adenoma arises from cortex, where sympathetic nerves directly drive the medulla. Mechanism: cortical growth, benign adenoma, no secretions of cortisol and aldosterone, as well as the androgen axis. The silent neuronal link HPA and autonomic system are not strongly disturbed. The neuronal implications are important. No excess cortisol feedback, no aldosterone-driven severe hypokalemia, no adrenal medulla or adrenal medullary catecholamine surgery is expected. Diagnosis: CT, MRI should be there. HP axis should be ruled out if there is a increase in uh, uh, you can say the hormone release driven by the normal adrenal cortex. Step 3: autonomic catecholamine exclusion. Metanephrines are used when pheochromocytoma must be excluded. Step 4: aldosterone pathway. Aldosterone renin ratio is considered especially with the hypertension or hypokalemia. Treatment: if benign non-functioning, there is no need for any treatment. Uh, Surgery is not usually indicated for asymptomatic non-functioning unilateral mass. When treatment changes, different aspects should be considered: hormone secretions, growth or suspicions, large or heterogeneous mass, and compression symptoms. That is the neuronal teaching pearl, sweating, panic attack, or episodic hypertension. Reassess for catecholamine secretion for assessing the proper diagnosis. That if whether the benign is converting into functional adenoma. Stable lesion, low neuronal impact, review trigger. These are the few checkpoints that should be there for excellent prognosis. Patient front line. The gland has a benign inactive nodule. We monitor for sign that is um, active or suspicious, but nodule itself usually does not disturb brain or nerve function. That is the summary for today's discussion. Normal link like HPA axis through which different hormones get released. Disease linked non-functioning cortical adenoma is benign mass with clinical important hormone access. Clinical link no major HPA axis autonomic or catecholamine syndrome should be occur. That is the management link. Neuronal linkage is anatomical and regulatory, but usually clinically silent for uh, non-functional adenoma. Thanks and regards. Please like and subscribe this channel for further discussion on diseases.